Today, April 29th, we will be giving an update on COVID-19 vaccines and MS. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the clinic director at the Rocky Mountain MS Center at the University of Colorado. He is a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. This webinar features a lot of important information. If you missed something on a slide or want to hear it again, we will be archiving this webinar on our website, mscenter.org, so you can replay it at any time. We'll reserve time at the end to answer questions from the audience. You can submit your questions at any time by typing them into the chat window on your screen using the Q&A feature, or you were able to submit them at registration. We will answer as many questions as time allows. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, we'll turn it over to Dr. Alvarez.
Hi, so thank you very much for coming in today. I think it became clear that the information evolves rapidly, and so there was a lot of questions around should we get vaccinated or not, and so that's part of the reason for doing this quick follow-up after the last program event, and we'll try to provide some guidelines. And again, for that, that's kind of my views and kind of go from there. This will be a little bit shorter talk than what we've been doing, but I wanted to leave a lot of time for questions and answers at the end of the talk. So I'll go through a little bit of stuff, a little bit of new data that just got presented about a week ago, and then we'll get into the question and answer period. So I am going to present a little bit, numbers really short. I'm going to summarize a little bit of more information about risk factors. We'll talk a little bit about how vaccination has gone, and that'll be really pretty short. And then again, this guidance kind of some suggestions without really probably getting into a lot of hardcore guidelines because we don't have those. So just to present a little bit of the numbers and kind of where we're at from a US perspective. And I realize that I'm not sharing my screen, so let's start sharing screen. All right, I think that's coming through, and if not, Kelsey, please let me know.
You're good.
Perfect, thank you. So on the type panel here, we can see that there was starting to be a bump in the US. We can see that that's starting to kind of come down. Colorado, we're still kind of inching upwards a little bit, and we'll show that here in a little bit. The concern and delay in hospitalizations, and then particularly in deaths in the US isn't currently too bad, but we can still see that we're still having a lot of deaths related to COVID, and that it tends to rank still in one of the top reasons for deaths in the United States. This is in stark contrast to what's happening across the world. It's very clear that we're having, I don't know, the fourth spike, if we can start calling it that. But for people who have not been paying attention, for example, India is like running out of oxygen, and in some countries it's really bad situation. And so we're having a huge spike in the world. A lot of this is driven by the predicted overtake of the variants. The variants do appear to spread a lot easier, probably about 50% faster, easier. Maybe not associated with higher rates of death or mortality, but if you have that many more cases, the number of deaths is going to kind of continue to go with it. And so that's a big concern. When we look at the numbers in Colorado, we were starting to kind of get this bump. They've been stabilizing again, so that's a great news. And the prediction is for them to kind of continue to decrease if people can continue to get vaccinated as planned. It is expected that within a couple of weeks, that supply of vaccines, at least in the US, will exceed demand, which is awesome news. I hope it doesn't mean that people just don't want to get vaccinated and that everybody that's want to get vaccinated is vaccinated, but hopefully it means that people that we're actually just getting more vaccines. So that's fingers crossed. That's hopefully what's happening. So this is kind of the summary for just risks for MS patients. We have to understand these in order to kind of provide, I think, good guidance. Age is a huge one, especially as we start to look at patients over the age of 70. And then it seems like it kind of plateaus down a little bit after that. 50, 60 is still a little bit of a concern. But really, especially for death, getting it when you're in your 70s or older has a particularly higher risk. Males a little bit over females, maybe a twofold increased amount of bad outcomes. Comorbidities, and these are not in any particular order, but heart disease is probably the highest one. And here we're talking mostly patients with bad heart failure, much more so than high blood pressure, which is still a risk factor. Respiratory disease, particularly with COPD, much more so than asthma. And then you have a lot of conditions that increase it a little bit: diabetes, chronic renal failure, chronic liver failure, cancer. If you're on immunosuppression, that's a little bit higher, things like this. It appears that MS is not a risk factor, but maybe being on B-cell therapies is a little bit of a higher risk, and that we'll learn a little bit more about, as well as disability level. And so it's important to kind of go through these things and be like, ooh, I meet a lot of these, or no, I don't meet any of these. So that then really drops your risk. So this is, for people that have been following these, there was a French study, a big Italian study. A lot of other countries have since kind of started other studies, and the US has one called COVIMS by the National MS Society. There was an MS Alliance group that then combined a lot of these. We just had the American Academy of Neurology meeting last week. And so this is kind of an updated sliced data about the Italian study, which is now, I think, almost doubled in size to about 1,500 patients. And here we can see that as we start to kind of look at the age breakdowns, anywhere from, as we start to get into the age 45 to 60, there's about a 1.9 or almost twofold increased risk of getting COVID. Over the age of 60, it shoots up over 7.7% or 7.7-fold increased risk. The way you would read these numbers is being female, being a woman has a 35% less chance. So one being kind of an even break, a smaller number gives you kind of what fraction of that would be decreased. Any fraction over that would be increased. So in this case, it'd be 35% less risk for women. For EDSS, which is disability level, for each step in disability that you go up, there's a 17% increase. For comorbidities, 103% increase, or basically a twofold increase. Getting steroids, this was really almost like a sixfold increased risk. As the numbers got bigger, this has dropped, but still significant at almost 2.5-fold increased risk. When we start to look at drugs, we see that interferons, which our body uses to fight infections, are actually maybe protective. With almost a 2/3 fold reduction in chances of getting COVID. When you start to look at B-cell therapies, almost a twofold increased risk. This number has dropped a little bit compared to their prior publications, which is great. And on the right side, we can see a little bit more of a breakdown of this. So not that they had a ton of cases with rituximab at 27 or ocrelizumab with 153. But a couple of things that we see is that rituximab was a little bit worse than ocrelizumab. So not to put people on rituximab on edge, this appears to be primarily driven because patients on rituximab have been treated longer, since ocrelizumab is a relatively new drug. So as you start being on treatment for more than 2 years, that drives most of this trend. And you can see that over time we just get this increase, and it might be associated with Over time, we see decreases in white blood cell counts, particularly lymphocytes, with antibody levels, which are all protective. And so if those numbers go down, you're a little bit at higher risk. So very much in line with what we saw before, and just kind of helping confirm that as we start getting more numbers, that that things are still making sense with kind of the data that we've been putting before. This is the MS Alliance. This is a little bit older data, but just because it's a larger group, again, showing kind of the similar trends, women being, being a little more protective compared to men. As age goes up, you can see this increase. I like this one just because I'm a figures guy. Pictures work for me. As you start to look at types of MS, at disability, you can see these fold increases, which, get looked at a little bit differently. Here, it's just over 6, which means a cane, compared to patients that don't require a cane for walking, almost a 7-fold increase. We also have to look at different types of versions of bad COVID. So just getting hospitalized versus being put into an ICU versus ventilated versus death. You can see these big differences. This did not get broken out for the Italian group, but we can see that these risks appear to go up until you get to death. And that might make a little bit of sense, again, and I've shown this figure before, is that early in the disease process, it's mostly a bad disease because of the virus, and later on, it's mostly a bad disease because of the immune system. And so sometimes you get to a point where by controlling the immune system can actually be helpful and protective. And so even though, for example, steroids are bad here, they're often used in patients who have COVID and are in the ICU and have a protective effect. And I think that helps illustrate this really well. To show this again, rituximab is not a non-common source for infections. And so patients on rituximab have higher levels of serious infections. This is from a Swedish group, and compared to other drugs, you can see that it has a much higher risk of serious infections. We did this study with Dr. Keister at NYU. And here again, it highlights that being in a wheelchair really increases the risk of having bad outcomes. It's particularly, here we have a little bit more broken out risk. So being a walker is a 3-fold increased risk, and a 1.5, so 69% increased risk if you need a cane. Being on rituximab over time looks very similar to the other stuff. So again, it's making sense that we would see this. The longer you're on rituximab, the more risk for serious hospitalizations here as well. If you've been on immunosuppression like chemo type drugs, a little bit more risk. If you're male, a little bit more risk, and things like this. So when we start looking at the immune system, it's important to kind of get a quick review. And this just happens to be talking about the virus for COVID, the SARS-CoV-2, and to kind of show layers of protection. So one of the main layer of protection is the physical barrier, skin and things like this. Once you get past that, then you have to deal with things that kind of can kind of kill infections a little bit more broadly. So natural killer cells, different cytokines, chemokines, cells, different proteins that the body makes to kill viruses can kind of do that. These infected cells start to produce some of these things. They help activate macrophages, which can sometimes just eat up the viruses and things like this. So one of the things I like to highlight is that, if you get a little bit of virus versus a lot of virus, if you have a little bit of virus, it gives you a chance to mount some of these immune responses, and for this to kind of get kick-started and help fight the infection before you get a bad infection. If you get a lot of virus, that can be bad. So this is where the washing your hands, wearing masks becomes important, because even if you get exposed to 1 or 2 virus particles, you probably will not develop symptoms to COVID and just kind of fight it off naturally. Once you get to this point, we call these antigen presenting cells. So macrophages, actually B cells, other types of cells will eat up these virus particles, chew them up, and present them to B cells and T cells. B cells can also present it to T cells. they work together. But we think of then B cells as going on to make plasma cells, and then plasma cells making antibodies. T cells tend to kind of produce a lot of chemicals that can then attack the viruses as well, or help protect these cells, help them fight infections and other things like that as well. So we need all these different parts of the immune system, and different drugs affect this in different ways. Tisabri or natalizumab prevents these cells from getting into the brain and the spinal cord. So if this was a virus that affects the brain and the spinal cord, this could be a big deal. It doesn't tend to do that. And so natalizumab doesn't seem to have much effect as far as developing bad COVID. Things like B cell depleting therapies, they take out these cells. That doesn't let you then form good antibody responses. It may not let you present the virus to T cells as well, and kind of activate this part of the immune system. So there's been a lot of concern for therapies that specifically affect B cells. And even though we've said that MS was traditionally a T cell disease, there's not any therapies that we use that affect T cells and not B cells. Now that we know to look for effects on B cells. So now that we understand that there's different parts of the immune system, we can understand and evaluate some of these. So this is very new data. This got presented by Dr. Keister. You might recognize the name, the guy that we worked with earlier at New York University. And so he's been working with his research colleagues there to look at antibody responses as well as T cell responses. And this was presented again last week. Since New York got hit early, they had plenty of patients to study. And this is not a vaccine study, but this is looking at sort of responses for people who that were infected with COVID. And what we can see here is that depending on different types of systems, you may see more or less responses. So if you look at this way to detect for antibodies, the Alexa system, you see that 58% of those on ocrelizumab developed antibody responses, but a whopping 97% did if you were not on ocrelizumab. If you were on ocrelizumab, very little difference on the NYU multiplex bead assay, looking at neutralizing antibodies with another assay, a little bit of a difference. Statistically, maybe not that much, but the numbers are a little bit lower. I think this is important because the presence of antibodies only tells part of the story. If we look at here, this is these numbers representing number of antibodies, so these numbers here, we can see that their level of detection is 10. All of these patients were considered to have antibodies, even though the levels are much lower than these. You can see sort of where the average is. And overall, the patients had much higher levels. So if you look at it by those that had antibodies versus those that didn't, not statistically significant, but you can clearly see that the amount of antibodies overall was much higher in those patients who had that were not on Ocrevus versus those that were. And so this is a study that when I talk to my colleagues, for example, I've heard different interpretations of it. And some people are like, oh no, most everybody develops antibodies. And some people are like, oh, but they don't appear to develop really good antibodies. So this is where understanding the technology and the methods is a little bit important. Anyway, I think he goes on to make the statement that antibody responses in time drop off and aren't as good. And I think this helps highlight that the number of antibodies do not appear to be as good. We can look at T cell responses. And so patients who were on Ocrevus versus not on Ocrevus actually maybe, not significant, but had T cell responses that were actually pretty much in par with those on Ocrevus, a little bit higher on average. This is another assay for T cell responses, and again, very similar. I think it's important to notice how some people develop really strong responses, in the 3,000s, 4,000s, and some people are hanging out like in the 200s, 100s, and that kind of thing. So this is kind of a little bit of highlighting the, little bit of an immune response versus no immune response. These were patients who were not infected at all. These were patients who did not have MS and developed COVID. And they still mounted a bit of a stronger T cell response on average. Some people did, some people did not. And again, very similar with this other assay. But here, for example, in this other assay, you can see that without Ocrevus, nobody really mounted an immune response if you were COVID negative, for example, if you did not have the infection. So maybe a little bit of a cleaner assay as you look at this test. So you can see their conclusion here, and the quality of the slides not great, and I apologize for that, but I stole these from a presentation, so it's not the best way to do this, and I apologize for that, but I think the point is able to come across and still read their conclusion, which is that preliminary results suggest that antibodies, that's what the AB is, and T-cell responses to SARS-CoV-2 can be detected in MS patients 9 months or more after infection. Antibody responses, but not T-cell responses, are attenuated, are blunted out in those patients who were on Ocrevus. So I think that is kind of my main takeaway, that B cell stuff appears to be really kind of affected. T cell responses appears to be still pretty okay. Again, this is to people who got exposed to COVID, not responses to COVID vaccine. To highlight this a little bit is that patients who can't make antibodies, that have a genetic mutation called X-linked A-gamma globulinemia, who develop COVID pneumonia, still were able to recover. Telling us that part of the immune system was able to take care of COVID, and that again suggests that it was those T cell responses. So when we presented this last time, it showed again that after the first vaccine and now after the second vaccine in this one, that patients who were not on Ocrevus had much higher levels of antibody responses than those that did not. And the one thing that's a little bit different on this assay is that we can actually see what's kind of considered to be protective put on this graph, which is not on the graph from the New York group, for example. And here we can see that overall, after vaccine 1 to vaccine 2, for example, that the amount of antibodies did go up, but they just weren't to the level that we might consider to be protective. And I think this helps us kind of maybe understand a little bit of that prior graph as well. None of the patients had antibody levels to that of anybody in the control group. So we've gotten a few questions about being able to join that study. We're kind of getting, I think, the information and are trying to get that information out now. So we're not adding much to kind of the local study. There's a study that actually just got approved today, and we'll look at recruiting for next week that Dr. Piquet is leading. That's going to look at the B and T cell responses, actually the same assays that Dr. Keister is going to do for patients on Ocrevus. And these are looking at people getting vaccinated with the RNA vaccines strictly. And so we are starting this study as early as next week. So if there's somebody out there in the audience who wants to be part of these studies, has not been vaccinated to Ocrevus, has not been vaccinated against COVID, who is on Ocrevus, we would love to have you in this study. These are patients that are going to have 5 blood draws. And the important point here is that we need a blood sample before the vaccine. I think a lot of our patients have already been vaccinated, but I know there's a few of you out there still who maybe haven't been vaccinated. This is a number you could call to be involved in that study, and they will help you arrange for vaccination. They'll sign you up, at least through University of Colorado, to get vaccinated on campus. I think it's important to recognize that, okay, maybe the immune responses aren't great. And for people who have listened to me in these talks before, have heard already the story that I responded like crap to the hepatitis B vaccine. And I had to do a double dose type of paradigm similar to this. This was a study actually done in alcoholics with cirrhosis or liver disease and those that did not. And you can see here that people who got the standard dose had a much lower response than those people who had a high dose, meaning that they got 2 shots whenever they went in and actually had an extra shot. So 3 shots versus 8 shots here. And so you can see that there's strategies for trying to boost up the immune system, and will be part of studies looking at trying to boost up the immune system after, for recognizing for people who maybe don't develop antibodies. I think this will become important. And so we're trying to figure this out. Unfortunately, there's no extra vaccine to be had, but I think again that's going to change in the next few weeks, and then we can start doing some of those studies. So stay tuned for that. So this is my big summary slide. So what do we know? So I think patients with, and a lot of our questions are kind of centered, what does it mean for patients on B-cell therapies? For patients on other types of therapies, it appears that the immune response appears to be pretty good. There's been some discussion around maybe Gilenya, patients on Gilenya not responding as well either. But at least for B-cell depleting therapies, that B-cell responses to vaccine are not great, but they don't appear to be the whole story. T-cell responses are important, and they appear to be a little bit better. The vaccines don't always protect everybody for whatever you're vaccinating them against, so that's important to know, but at least appear to protect from bad COVID. From deaths, from ICU stays, and things like this. We're getting a lot of hearing a lot of stories of patients who have been vaccinated who are developing COVID, whether they have MS or not. And so it means that even though you get vaccinated, you have to be careful. But again, if you don't get vaccinated, you will not have any protection from the vaccines. And again, it highlights the importance of the vaccines that I didn't get too much into it, but these vaccines appear to be very, very safe. There's been some discussion around the Johnson & Johnson vaccine. It went off the market, it came back on. The number of clots from that vaccine is still lower than it is for birth control. And so I think they're very safe vaccines still to this day. I think the other part that we have to look at is the mental health component of everything. This is huge as we start to get vaccinated and things like that. We need to start figuring out how to take care of our mental health with this. That means getting out of the house, trying to exercise, eat right, hanging out with other people. And so the advice around this part is if you trust the people that you're with, if they've been vaccinated, especially, I think it makes sense to get rid of the masks and have a good time with them. If you trust the people to tell you, hey, I've had an exposure to somebody with COVID, hey, I'm not feeling very well, let's cancel and get together next week. Those kind of situations. If you are going out to eat and you can see that the wait staff are wearing their masks, are being careful about things, I think those are safe restaurants to be at. I would probably not go to a concert with 1,000 of my favorite friends and hang out, within inches of each other. Those kinds of things at this time. I think we need to see that the numbers really start to continue. Yesterday was the first day at the university where our numbers started to dip here in Colorado. So I think maybe we're starting to turn the corner for this last fourth, fifth to sixth wave that we're in. But I think it's important to kind of try to get back to normal as much as we can, just from a mental health perspective. And so I think with that, this was just extra slides. So yeah, so with this, I just want to thank you, and we can turn it over to questions.
Thank you very much. Folks, you can submit questions through the Q&A feature. I will start with a couple of the questions that were submitted at registration. We had a lot of questions regarding specific DMTs and timing. So I just wanted to see if we could kind of summarize that part again.
Yeah, so this is a great question. So of those two people who developed antibodies, one of those patients actually got treated in between the two vaccine doses and developed good antibody responses. So I'm not sure that it makes too much of a difference, but our current suggestions are and this applies to the B-cell infusions, the every 6-month infusions, is to try and wait out the infusions for about 4 weeks, one way or the other. So especially with the infusions, we know that we can push infusions out for 2 months. We did that at the beginning of the pandemic. There's studies that have looked at only getting a dose and then following patients for a year. So we know that extending doses can be pretty safe and still have pretty good efficacy. And so in that situation, all the times we just recommend get vaccinated and then push off your infusion. We try not to get them too close together because should you have a reaction, we want to know if you reacted to the vaccine or the infusion, and those kinds of things. It doesn't mean push off your Tisabri infusions. We want to have your Tisabri infusions continue as scheduled. Some of these therapies, some of these drugs and treatments have a rebound of disease activity. So it becomes really, really important to continue those treatments and kind of continue doing those. And so 2-4 weeks, particularly, I think is a good gap between them.
And I know you talked a little bit about all of the different ways that different studies are looking at the antibodies. Can you go over, a lot of folks had questions about if they're on B-cell therapies, should they get antibody testing? And I know we don't know if boosters will be available yet, but maybe just talk a little bit more about that.
So we often talk about in medicine that we should only do a test if it's going to change something. And at this time, because we don't have the boosters, it's not like I can say, oh, just get more vaccine if you're negative. So at this point, it really wouldn't change anything. The tests that we have just say whether you have antibodies, not whether you're protected or how protected you are. And so it doesn't give us a great sense to tell us, you know, hey, it's okay to take your mask off. We're still recommending wearing masks and things like this. So at this point, I don't think it makes too much sense to get tested. But I think this is going to change in the next few weeks to a month. If we start getting access to other vaccines and can start doing boosters, then I think it becomes important to be able to get those test results and then see, and maybe if that leads to a general agreement that, hey, maybe we should do a third shot or a fourth shot, those kinds of things. We still got to figure out a little bit what those booster regimens should look like. And so I think that that's a little bit of to be decided, but I think that we're getting closer to that day where we're going to have to start making those decisions. So the answer I think is not right now, but I think soon we'll start recommending people to get tested.
And we are still having questions come in regarding the timing. The National MS Society guidelines say 12 weeks, which is quite a bit more. And then also, does your immune response improve if you haven't had an infusion for 8 months?
Yeah, so let me address the second one and then I'll get to the first one a little bit. So it's not like the B-cell therapies are working and then they stop working, or that the immune system is not there and then all of a sudden it just comes back. And so there's nothing magic about any one day. If you wait it out, the immune system appears to get better. We did have patients that were 7 and 8 months out in that study and still didn't mount great immune responses. The other person, besides the one that got infused right in the middle of it, was somebody whose B cells had started to come back. But we had patients whose B cells had started to come back after their infusion and still did not mount a good immune response. So waiting out and pushing off the infusions for like a year or waiting for B cells to come back, then we have to start weighing in the risks of what's the MS going to do. And because of that, I think my recommendation would be is to just get vaccinated. We'll figure out the booster stuff. We'll get you some protection because this timing of the infusions doesn't seem to matter too much. Regarding then the first one and the different recommendations. So yes, this is the problem that we're having, is that different people are coming up with different guidelines. And it's not, again, that there's anything different at 4 weeks than at 12 weeks. The 12 weeks from the National MS Society, by the way, comes in as you've gotten an infusion, you should wait 12 weeks before getting vaccinated. But the number one guideline from the National MS Society is get vaccinated. if you can move things around and you have some flexibility, then moving things to, the 12 weeks or 4 weeks before, this kind of stuff. But again, there's no data at all to say that 12 weeks is any better than 4 weeks. We didn't see that. We have small numbers. I get that. But it is one of those things that I think the number one thing is, if you don't get vaccinated, we know what your response is. It's going to be zero. And as you get, a third or a fourth shot, I think we can deal with it. And if you're going to wait an extra 3 or 4 months, at that point, we will have extra booster shots that we can figure this stuff out. So get some protection at least early versus waiting around, pushing off infusions and risking getting an MS attack or things like that. So I worry less about the timing than I worry about just getting vaccinated. If I can emphasize one point, it's get vaccinated.
Excellent. Is there any concern that the vaccines will make MS-DMTs less effective?
No. At this point, there's no suggestion that that should affect it. And I can't think of potentially why that might be the case. We're getting a few kind of the opposite questions as well, whether or not a vaccine can trigger MS relapse. And at this point, I think that question is a little bit hard to answer right now, because almost everybody's getting vaccinated now, and so everybody who's getting a relapse now, we're getting a lot of people who just happen to maybe have been vaccinated in the past few weeks or things like this. So we've seen some cases of that in our clinic, maybe 2, 3 of these types of patients. So it's hard to say that they're linked, because to be honest, it seems like over the last month, almost all my patients have been vaccinated already. And so I would say that at this point, I'm not particularly worried about that. If you're on disease modifying therapy, then the chances of that would be less. And it would probably make the vaccines safer from that perspective, because they would provide the protection against the relapse from the vaccine, if that was going to be the case. So again, I'm not sure that there's a link, but theoretically, it might be a little bit protective in that regard.
As far as treatments for COVID go, or outcomes, I suppose, do we know if the vaccine still prevents severe COVID and death in patients with MS, particularly on B-cell therapies? And are antibody therapies like Regeneron still able to be used for people on B-cell therapies?
Yeah, so right now there's no contraindication for any of the approved or drugs being used to treat COVID because of MS or because of any of the disease-modifying therapies, treatments that we use for MS. So in that regard, it doesn't block you from getting treated. What was the first part? Sorry, Kelsey.
Do the vaccines still prevent severe COVID and death in patients with MS?
Perfect. Sorry about that. So we're not seeing, I have yet to hear about somebody who got vaccinated who died from COVID. So it looks like what that means is a little bit of antibody protection in those people who maybe don't mount a great immune response is still protective for the really bad forms of COVID. Since it hasn't happened in the general population, I've obviously not heard about an MS patient dying after having a COVID vaccine. We did have a patient develop COVID after a COVID vaccine on one of the MS therapies. But again, if you've been watching the news, this has been happening sort of across the board for people without MS. So I'm not surprised that we're getting patients with MS developing COVID after the vaccination. But the severity is really low in our patient. The one I heard about this week just basically had upper respiratory infection, basically had the sniffles for a few days. So I think, from that perspective, it's encouraging. And I think reassuring to kind of continue to, this line of just get vaccinated.
This is a two-part question. It's a little specific, but I think it covers a lot of questions from folks. The first part is Gilenya considered a T-cell therapy, and this person is on Gilenya and their doctor is talking about potentially putting them on Ocrevus because their white blood cell counts are lowering, but they're also in a wheelchair, so now their Ocrevus is sounding very concerning.
Yes. So Gilenya is one of those drugs that when we first heard about it was a T-cell drug because it kept those T cells kind of clustered up in the lymph nodes, which is why when you're on those types of drugs, and I'll make it a little bit more generic to all the other drugs in that class. So that includes now Mayzent, ozanimod, and ponesimod. And so those patients do have low white blood cell counts. And this was a huge concern when these drugs came out. The drugs lower the number of a type of white blood cell called lymphocytes, and then B and T cells are type of lymphocytes to levels that are in the range of 200 or lower. And to give you a rough idea, within T cells, then we talk about CD4 type T cells. Those are the ones that get affected by HIV. And these patients would have CD4 counts in the range of full-blown AIDS, pretty much. And so it was a huge concern. And what we don't see are patients on these kinds of drugs developing full-blown AIDS and the infections that kind of go with it. So even though the numbers are low, it's telling us that the B and the T cells, by the way, the B cells are just as affected as the T cells by these medicines. That the cells that need to get out of the lymph nodes are getting out of the lymph nodes and providing some protection. We don't put these patients on things to prevent infections or anything else like that for prophylaxis. And so from that perspective, we think of these medicines as, again, not necessarily being associated with bad COVID in particular when we look at that infection. And again, that's been looked at in a number of these studies, kind of with a fairly neutral ability to kind of get COVID or things like that. I think the concern about switching to Ocrevus because of an infection concern then might be a little bit backwards. I would consider Gilenya to be a little bit of a safer drug in these kind of situations, specifically related to COVID. Just COVID infections do appear to be a little bit worse. Not a huge amount, but in that range of 1.5 to 2-fold increased risks. And so than with Gilenya or some of the other therapies. There might be some value if the patient's progressing, because there's data on progressive disease. And you have to weigh, again, the other risk factors. If there's a lot of comorbidities, if the patient's older, there's wheelchair patients and then there's really bad wheelchair patients. So you have to, they're not, it's not black and white. You have to weigh all these things to kind of try and make that decision.
What are some side effects from Pfizer or Moderna vaccines that patients should be aware of as a way to prepare and be able to separate out relapse from a pseudo-relapse?
Yeah, perfect question. So I'll break this up into 2 parts. The main thing you're going to expect is to get a bump in the arm where you get the shot. And it's going to feel sore. It kind of feels like you do with the flu or things like this. After the second one, it's a little bit more common to end up with kind of flu-like symptoms, fevers, headaches, those kinds of things. We did not see a huge amount of other stuff, nausea, belly aches, or things like this. And we asked our patients about that. They're just overall, they're just a little bit higher with the second shot. I felt beat up after the second dose. I had a day where I was glad I just had meetings and I sat in front of the computer and just talked to people for a day and was happy to do that. My wife ended up developing fevers and chills and was in full rigors that night. By the time we got her some Tylenol, she was back to normal without fevers and just kind of feeling a little bit beat up afterwards. Those tend to last maybe 12, 24, 36 hours, something like that. It doesn't tend to extend much more than that. To kind of see some swelling at the arm, that can last, up to a week or two. So we can definitely see a little bit of that. But we should be, pretty good, and, not much of that. We've had almost all my patients now get vaccinated, and, again, haven't heard too much about kind of worse symptoms after that. So again, really safe vaccines, with, yeah, some stuff, but pretty minor and self-limited.
We've had a lot of different questions about what folks should be thinking about caution-wise after they've been vaccinated, particularly when they're on the CD20 medications. Are folks able to follow the CDC guidelines that they're releasing that are kind of loosening up the restrictions? Should they be more cautious because they're on these B-cell therapies and they don't know the full extent of their reaction?
I would say yes and yes, right? So in an environment where you're controlled and you know the people that you're going to relax in your situations in, I think that that's the part where I would feel really comfortable recommending that you lose the mask, that you just hang out and have a good time with friends. Some states have opened wide up, and so and that doesn't necessarily mean that I would again go to concerts, really crowded restaurants, things like that. Those people you don't know, they might be going out and they might be having fevers and still going out. You can't account for common sense in people, and so that's kind of where I would be a little bit more cautious and careful about it. If you can do things outdoors, it's better than indoors. And again, you have to look at the comorbidities, your age, some of these other level of disability, all these other things to kind of say my risk would be, really low. My risk would be a little bit higher, and kind of adjust kind of what you do around that time. So it's a hard one to kind of put a blanket statement across. And that's why I went through so much of the data to kind of say, yeah, I'm on the low end, so I can open up a little bit more. I'm at a little bit at the higher end. I should be a little bit more careful. And that's what I try to do when I'm, across from a patient and try to provide guidance to them. But I think it's important not to sit at home and not do things. I don't think that that's good for mental health and for our well-being. We're seeing a lot of depression, a lot of anxiety, a lot of people who are deconditioned because they're not getting any exercise, and things like that. And so we really got to stress, the ability of people to kind of start living a little bit more normal lives as much as possible.
Is there any data on the long haulers effects of COVID and people with MS?
Yes, there's a little bit of data from the UK that got presented at the American Academy of Neurology. A lot of the same factors that I've been talking about with bad COVID, with bad reactions to the vaccine, things like this, do not appear to predict who's going to have long hauler syndrome. The factor that appeared to have the biggest effect on long hauler syndrome appeared to be patients who had anxiety and depression at baseline. And so I'm not sure that I know how to connect those two, but from their data, that appeared to be kind of the biggest predictor as to who was going to develop that, the longer term issues with COVID.
And I know that we are over our time, so I'll wrap it up with just one more clarification that MS in and of itself does not seem to affect response to either COVID or the vaccine. So if you are someone with MS but not taking medications, your levels are of risk and vaccination are the same as someone without MS or similar.
So zero increased risk from MS by itself. MS has zero effect on your ability to fight COVID. The one exception that I can think about are for patients with MS who have higher levels of disability. That level of disability will increase the level of serious infections, whether it's COVID or anything else. And so that's an important distinction. It's not necessarily the MS, but that disability was created by MS. So kind of depends on how you want to think about it, I guess. It's less about the immune system being affected, but what happens is if, for example, you have some chest weakness, you're not going to be able to clear your secretions as well. So you're a little bit more likely to have aspiration pneumonia and have problems from that. If you are wheelchair bound, don't move around much, you might have some more chances for bed sores and other things like this, and can get infections that way. And so I think that becomes really important. I just saw also then, and I forgot to answer the question around pseudo relapse versus relapse after an injection. So let me cover that just real briefly as well. Pseudo relapses versus relapses are both clinically having symptoms that sound like MS. But the difference is that with relapses, it's inflammation driving that. So new lesions popping up on the brain. In pseudo relapse, it's your body not being able to compensate to old lesions. What that means is they tend to be symptoms that tend to be your typical symptoms. Meaning if you traditionally get numbness or weakness of your right foot, when it's hot outside, you have a cold, you haven't slept well, you're dehydrated, stressed, anxious, those kinds of things, end of the day type things, your right ankle will get a little bit weaker. That tends to be what we tend to see post-infection from a pseudo relapse. So because you, as I mentioned, you are a little bit more likely to have fevers and things like this. Almost 70–80% of patients who have gotten the COVID vaccine that we looked at had some fevers and chills and headaches. That will make it much more likely for your old symptoms to kind of come back and kind of show up a little bit as a pseudo relapse. As soon as that fever comes down, you take some Tylenol, ibuprofen, Aleve, that temperature controls, the symptoms should get back to their baseline. You're going to feel a little bit maybe cruddy for an extra few hours or something like that. And so they'll kind of gradually get better as those symptoms kind of get better.
Awesome. Thank you so much.
Perfect. Well, so I'm glad it was because of your questions that, we did this session. I think it was helpful to kind of have some clarifying responses, as I understand that, in my last presentation, I wasn't maybe as clear as we needed to be. And so it was great for, for us to be able to kind of clear this up. So these questions are super important. If something wasn't clear today, please let us know. I think then we can help address them and kind of hit them over the head a little bit easier, a little bit more. Until we can get them clear for everybody. So with that, I appreciate it, and thanks for the opportunity to come back again today.
Thank you. And yes, if you have further questions or ideas for other webinars in the future, we just put a link to our evaluation in the chat, and that is the best way to get us information and feedback. So thank you guys. Have a great day.